This conference will now be recorded.
Okay, good morning, everybody. Am I audible to all of you? Good morning, everybody.
Yes, sir.
Hello. Am I audible?
Good morning, sir. Yes, sir. Audible, sir.
Okay, fine. Today, we will be discussing about optic neuropathies. So now, what are these optic neuropathies? In the eye, we have a nerve called optic nerve. When there is an inflammation or swelling or damage to the optic nerves due to either infectious or non-infectious reasons, we call it as neuropathy. So the infections can cause optic neuropathy. Neuropathy means just simply in simple terms, it just means to say that the optic nerve is affected. It could be due to infectious or non-infectious causes. It could be there will be an inflammation or there could be a swelling, anything. So whatever damage to the optic nerve has occurred due to various etiologies, we suspect them or we put them under a single term, optic neuropathy. When there is an inflammation, you call it as itis, neuritis. That is nothing but optic neuritis. When there is no inflammation, you just say, you use the term neuropathy. Okay, so it could be neuropathy is mostly used for the conditions which are non-infectious. Whenever there is infections, you use the term neuritis or retinitis or papillitis. So different terms are used, but usually these are the commonly used terms. Neuritis means you are either suspecting inflammation as the main cause. Inflammation could be mainly because of infections or due to other causes. Neuropathies are usually due to non-infectious causes, either due to ischemia or due to hypertension, any other cause other than which has not led to the inflammation of the optic nerve and there is a swelling of the optic nerve. So today we will be discussing mainly about the clinical features, how do you investigate, and what are the basic presentations of optic neuritis. My topic today is anterior ischemic optic neuropathy, but before going into anterior ischemic optic neuropathy, I will just briefly brush through optic neuritis because you will have to differentiate what is the difference between optic neuritis and other non-infectious causes like anterior ischemic optic neuropathy. So we will just briefly run through optic neuritis and then we will go into the today's topic, that is anterior ischemic optic neuropathy. So what are the signs of optic nerve dysfunction? So whenever there is optic nerve dysfunction, three main features are affected. Externally, you will see three main features which are getting affected. That is, one is pupil. What will happen to pupil? Pupil, there will be an afferent pupillary conduction defect. That is nothing but RAPD. Say that there is a relative delay in constriction of one pupil compared to other, or delay in relaxation. So when you throw light on one pupil and see the simultaneous reaction in other pupil and come back to the same eye, there is a difference. Both ideally should be symmetric. When there is a difference, you talk it as relative afferent pupillary defect. Relative, in simple terms, the input or the message which is transferred from the optic nerve, the afferent fibers are slightly functioning or slightly malfunctioning in one optic nerve compared to other optic nerve. Both are functioning, but one is functioning little less. Why? Because there is some problem in the optic nerve. Then you call it as relative afferent pupillary defect. So what will happen to vision? Obviously, when optic is affected, the vision will get affected. And dyschromatopsia, whenever there is a damage to the optic nerve or whenever the optic nerve is affected, there will be definite problems in contrast sensitivity and color vision. So these are the common basic features of every optic nerve dysfunction condition. Any condition which is having optic nerve dysfunction will have these four classic features. That is reduced visual acuity, afferent pupillary defect, color vision is affected, contrast sensitivity, that is nothing but diminished light brightness sensitivity is affected. So these are classic features of any optic nerve dysfunction. So what is the pupillary afferent and efferent pathway? This picture clearly shows what is the pupil afferent and efferent pathway. You can clearly see how the afferent and efferent are going. The red line you can see there, they're going up to the pretectal nucleus and then Edinger-Westphal nucleus, and the efferent fibers, the black line, is nothing but the efferent fibers through the oculomotor nerve, that is, which causes constriction of the pupil. The afferent is mainly from the optic nerve and then the chiasma and then the visual optic tract and so on till the lateral geniculate body. They do not synapse in the lateral geniculate body, but synapse in the pretectal nucleus. From there to the Edinger-Westphal nucleus, there is a decussation there, and then the efferent fibers by the oculomotor nerve. So this is the classic pathway. So what is happening in optic nerve dysfunction? This afferent, the blue and the red pathway are affected. There is slightly delay in conduction in one eye compared to other, that is relative afferent pupillary defect. So any optic nerve dysfunction will cause some amount of visual field defects. So what are the different types of visual field defects the optic nerve dysfunction can cause? Now when there is this is the visual field of the patient. If the central area is affected, it is called as central scotoma. If the optic disc, that is the blind spot, and the central area is affected, then it is called as centrocecal scotoma. If you see a defect something like this, this is called as altitudinal defect. It starts to extend from the blind spot and ends in the horizontal raphe here. So this is nothing but a classic presentation of an optic nerve dysfunction or visual field defects in optic nerve dysfunction. So if some single nerve fiber bundle is affected, then the dysfunction will be, or the field defect will be something like this. All these field defects will be seen in the eye which is affected. Say right eye is having optic nerve dysfunction, one of these field defects will be seen in the patient in the right eye only, because that particular side optic nerve only is affected. Now, if you see what are the optic disc changes which can occur in optic neuropathy, here are some examples. You can see this is the normal optic nerve head. You can see, but when there is a condition called as retrobulbar neuritis. Here, when you see in the patient's eye, the optic nerve appears to be normal, but the patient's vision has dropped. So when you examine the fundus, everything looks normal, but the patient is not able to see anything. Then you should suspect something called as retrobulbar neuritis. Means the optic nerve is affected behind the eyeball, which you are not able to see here. So that is the example is retrobulbar neuritis is one example. Now this is an example of papilledema. You can see the margins are fully blurred and the disc is swollen. There are few hemorrhages here and there, and cotton wool spots or those whitish fluffy like structures which are seen. These are nothing but, this is seen in conditions like papilledema, papillitis, neuroretinitis, anterior ischemic optic neuropathy. In some conditions, you see optociliary shunts. Optociliary shunts are nothing but new vessels which are growing, or the small vessels which are swollen up in between the vessels. So these are nothing but optociliary shunt. When you see such a feature on the optic disc, you have to suspect optic nerve sheath meningioma or optic nerve glioma. If you see this particular picture, the optic disc is completely pale. So this is a condition where there is complete optic atrophy. It could be due to retrobulbar neuritis, or it could be due to compression, or it could be hereditary. Any cause could be the reason for optic atrophy. Optic atrophy means the vision is completely lost. There is no visual acuity left in the patient. Now these are some investigations which we commonly do for a case of optic neuropathy, where you are suspecting optic neuropathy. You have to do a VEP, nothing but a visual evoked potential, which shows a increased latency or increased. This is the VEP, which is commonly done for a case of optic nerve dysfunction. It assesses the electrical activity of the visual cortex created by retinal stimulation. So it assesses completely how the visual pathway is from the retina till the occipital cortex. So that is one investigation which is commonly done. And the next one is MRI, which is commonly done for assessing the optic nerve status in case of optic nerve dysfunction. So this is in brief about optic nerve dysfunction. So what happens in optic nerve dysfunction? Light pupils are there is a decreased contrast sensitivity, decreased visual acuity, pupil is affected, color vision is affected. What are the field defects? Central scotoma, centrocecal scotoma, altitudinal field defect. These are the common field defects which are seen in optic neuropathies. What are the investigations which are commonly done to assess the optic nerve status? MRI and visual evoked potential. These are some investigations which are commonly done. So this is in brief about the optic nerve dysfunction. Now let's come to the classification of optic neuropathy. Here, as we already discussed, if there is an inflammation behind the optic disc and there is a decreased visual acuity, it could be due to retrobulbar neuritis. When there is an inflammation of the optic disc and when there is a blurring of the margins of the edges of the optic disc, then you call it as papillitis. It is nothing but when only the disc is involved, you call it as papillitis. Neuroretinitis is nothing but when disc and surrounding retina is involved, then you call it as neuroretinitis. You see hard exudates in the macula, which are also called as macular star. So the optic disc is swollen with macular involvement, then you call it as neuroretinitis. There are various etiologies which have been mentioned here. Neuroretinitis is commonly seen in infectious conditions like cat scratch fever, Lyme's disease, and syphilis. And optic neuritis mostly due to viral infection or demyelination or syphilis, and retrobulbar neuritis due to ethmoiditis or Lyme's disease or demyelination, which is the most common cause. Now coming to today's topic, that is non-arthritic anterior ischemic optic neuropathy. So what are the risk factors? The optic disc is very small. It has a very small cup. Because it has a very small cup, the nerve fiber bundles which pass through the optic disc or the optic nerve head is very small and it is crowded. So because of the crowding, sometimes when there is ischemia, the nerve fibers swell up. Now it is commonly seen in conditions of hypertension, diabetes, smoking, hyperlipidemia, collagen vascular disease, or severe anemia. The drug also like sildenafil can also induce anterior ischemic optic neuropathy. Now, what is the classic feature of optic neuropathy? The disc is swollen. So the disc is swollen. You can see here the disc is swollen here, and there is an altitudinal field defect. But the swelling of the disc has classic features. There is a sectoral swelling of the disc, means one particular quadrant of the disc only is swollen. It is not that complete optic disc is swollen, one particular quadrant. Say if you see here, this inferior half only is swollen, but superior half appears to be normal. So commonly it is seen between the age of 45 to 65 years, and the presentation is altitudinal field defect. Eventually bilaterally it can also be seen. Now, when you do an FFA, you can see the fluorescein angle. You can see the inferior half of the disc getting involved and the leakage in the inferior half of the disc, and which shows generalized hyperfluorescence. So this is an FFA to confirm that optic neuritis is there. That in that also it is mainly anterior ischemic optic neuropathy. So the classic features of anterior ischemic optic neuropathy are sectoral disc edema. Because a sector is involved, that particular nerve fiber layers are affected, and it leads to altitudinal field defect, The disc is small and it is commonly seen in elderly age group with features who have hypertension, diabetes, hyperlipidemia, and other risk factors. So, what are the other features of this arthritic anterior ischemic optic neuropathy? Now, the previous one what we saw was non-arthritic. Now we are seeing what is arthritic. Arthritic, here also the features are similar, but there are associated features like temporal arthritis. This temporal arthritis is there here. This arthritis is a common feature associated with arthritic type of AION. It is commonly seen in elderly age group. There is a headache, jaw claudication or jaw pain, polymyalgia, rheumatica, superficial temporal arthritis, and visual loss is acute. When you do an ESR, it is usually more than 60. C-reactive protein is always raised, and temporal artery biopsy is very diagnostic of this arthritic AION. So if you see the histopathology of this particular genital giant cell arthritis, we commonly come across few giant cells which are commonly seen, and there is a granulomatous cellular infiltration and disruption of internal elastic lamina. This is the lumen of the artery, and proliferation of intima and occlusion of the lumen. So basically, there is an inflammation of the artery which is commonly seen in these particular conditions. So what is the prognosis of this arthritic AION? The prognosis is usually the visual acuity is affected in these particular patients. So any arthritic or non-arthritic AION, or whenever there is an optic neuropathy, the classic treatment is steroids. You have to give treatment for whenever there is a decreased visual acuity secondary to optic nerve involvement. The classic treatment what is generally prescribed is steroids. So steroids usually is the main mode of treatment. So if you see the clinical features, there is a pale disc with diffuse edema, small splinter hemorrhages, which will subsequently go into optic atrophy. To prevent the progression into optic atrophy, these patients need to be started on steroids. Because it is an inflammation, the steroids is the mainstay of treatment. You have to give IV methylprednisolone for 3 days and then gradually convert it into oral and gradually taper it over a period of 15 days. So corticosteroids are started immediately as follows and constitute the main treatment. That is, you give IV methylprednisolone 1 gram per day intravenously for 3 to 5 days, followed by prednisolone oral 80 mg per day to be tapered every week by 10 milligrams over a period of next 1 to 2 months, and daily maintenance therapy of 10 milligrams mg may be continued for 1 to 2 years to prevent recurrences. The next clinical optic neuropathy which is commonly seen is traumatic optic neuropathy. So some cases we commonly come across where they have had an RTA and there is an injury to the head, and after some days they come to us with complaints of diminished vision. So what has happened generally here is the nerve in the optic canal is either stretched, or there is a shearing stress, or there is a small fracture in the optic canal which has damaged the optic nerve. These are some common causes which lead to this traumatic optic neuropathy. If you see the CT scan, everything might look normal, but if there is a shearing stress during, that is nothing but the optic nerve is stretched during the accident, it also can lead to traumatic optic neuropathy. So there is either direct trauma or indirect trauma to optic nerve in traumatic optic neuropathy. The clinical features is loss of vision or decreased visual acuity, and dilatation of the pupil is noted, RAPD, visual field defects. All the features are same as for any optic neuropathy. These classic clinical features are same for any type of optic neuropathy: RAPD, contrast sensitivity loss, decreased visual acuity, and color vision is affected. VEP shows reduced amplitude. This is the classic features of any optic neuropathy. So initially, if there is some fracture or something, it has been noted in the CT scan, you have to just treat the fracture, or if it is possible, then otherwise The steroids are the mainstay treatment and surgical decompression if it is required. Whatever it is, the prognosis of traumatic optic neuropathy is very poor. There is a very less chance, less than 10 to 20% of improving once the patient has traumatic optic neuropathy. The maximum improvement is seen within the first 8 weeks, 4 to 8 weeks. After that, there is no chance or it is less likely to improve. Now coming to ocular manifestations of diseases of CNS or the central nervous systems. So till now we have seen the other causes of optic neuropathies. The optic neuritis has been covered for you earlier, and today we have discussed two main topics, that is anterior ischemic optic neuropathy, AION, and traumatic optic neuropathy. The next topic today for today's discussion is ocular manifestations of diseases of central nervous system. So what are the diseases which can occur in the central nervous system? There can be infections, aneurysms, hemorrhages or intracranial hemorrhages, intracranial space occupying lesions, demyelinating diseases. So in our eye, the special feature of our eye is the only place where you can see our vessels in live and the nerves in live. There is no other part in the body, unless you cut open, you can see the nerves and vessels live. You just dilate the pupil and you examine, you can see the nerves and you can see the vessels. So eye gives you an indication, examination of the eye gives you an indication what is happening systemically for the patient, or what is you can also localize some lesions which are manifested in the eye to some area in the brain or intracranially. So any infections intracranially, aneurysms, hemorrhages, space occupying lesions, demyelinating diseases, all of them have ocular manifestations. So what are those ocular manifestations? We will go through them shortly. First, coming to infections. So what are the common infections we come across? Meningitis, encephalitis, brain abscess, or neurosyphilis. Neurosyphilis is rare nowadays, but let's consider that also in the infection. So any infection in the brain or intracranially can lead to papillitis. Papillitis, as I said, is nothing but inflammation of the optic disc to infection. So there, because of raised intracranial tension or because of the brain abscess or pressure effects, there can be paralysis of third, fourth, sixth nerve individually or in a combined fashion also. So a patient with tuberculosis can also present with lateral rectus palsy or sixth nerve palsy. And when you examine the when you do an MRI, there can be a tuberculoma in the pons of the patient. So an external manifestations like third, fourth, sixth nerve palsies or papillitis is common, and there can be an optic atrophy or choroidal tubercles. When you examine the eye, if you see tuberculoma or choroidal tubercles is nothing but a white patch which is seen in the retina, in the choroidal level behind the retina. So you can suspect tuberculosis when you see such manifestations in the eye. So when you examine the eye after dilatation of the pupil, if you see optic neuritis, you should rule out any intracranial infections. If you see any choroidal tubercles, you can rule out tuberculosis in a patient. Or you can, these are all just an indicators or ocular manifestations of a systemic infection or intracranial infection. Intracranial aneurysms. Now, what do these aneurysms cause? Or these aneurysms is nothing but swelling of the arteries. So when the arteries are swollen, what can what can they cause? They can cause pressure effects. So they can compress any nerve and can lead to various manifestations. So when there is aneurysm in the circle of Willis and internal carotid artery, what are the features it can cause? It can cause ophthalmoplegia, facial pain, or paresthesias, or Horner syndrome, and central and peripheral visual loss due to pressure on the intracranial part of the optic nerve and chiasma. So all these vessels which are very closely related to optic nerve or chiasma, due to pressure effect, they can lead to various manifestations like ophthalmoplegia or visual loss, paresthesias, or Horner syndrome. Why Horner syndrome? These sympathetic plexus are closely related to internal carotid artery. They are closely related to internal carotid artery. So whenever there is an aneurysm in the internal carotid artery, that can lead to presentation of Horner syndrome. So Horner syndrome is just a manifestation of an inner problem which is not seen. So when you say identify a patient to have Horner syndrome, the main thing is not identifying Horner syndrome. The main thing is to identify whether the patient is having any internal carotid artery problem, where there is any aneurysm in the internal carotid artery. These are all external manifestations. Whenever there is a posterior communicating artery aneurysm, because the third nerve passes between posterior cerebellar artery and posterior communicating artery, so superior cerebellar artery and posterior communicating artery, the pressure effect can press on the third nerve. So when it presses on the third nerve, what does it do? It causes third nerve palsy and it involves the pupil. So it is nothing but pupil involving third nerve palsy. So when you examine a patient with third nerve palsy, you should see whether the pupil is involved or not. If pupil is not reacting, that means you are dealing with a patient with aneurysm. It is an emergency. You have to do whatever you want to do in an emergency manner, because you have to get an MRA done, rule out where the aneurysm is and tackle it accordingly, because you are sitting on a volcano, because the aneurysm can burst anytime and there can be an intracranial hemorrhage and patient can collapse anytime. So these are all external manifestations. Whenever there is a cavernous fistula, cavernous fistula means there is a fistula between internal carotid artery and cavernous sinus. When such a thing is seen, such a thing is present, there can be pulsating exophthalmos. The eye will be popping out and going in back again. So this pulsating exophthalmos is commonly seen. What does subarachnoid hemorrhage present? If there is a subarachnoid hemorrhage, the patient is suddenly present with very severe, sudden, violent headache and third nerve palsy with pupillary dilatation, photophobia, signs of meningeal irritation, vomiting, unconscious. These are all various features which are commonly seen in subarachnoid hemorrhage. Terson syndrome is a condition which refers to combination of bilateral intraocular hemorrhages with subarachnoid hemorrhage. If the patient has intraocular hemorrhages associated with subarachnoid hemorrhage, then it is given a term called Terson syndrome. So these are all nothing but intracranial aneurysms and the pressure effects of those. Coming to intracranial hemorrhages. So what do these intracranial hemorrhages cause? Intracranial hemorrhages are nothing but when there is a hemorrhage within the brain or subarachnoid region. How do they present? There can be retinal hemorrhages or subhyaloid hemorrhages in the posterior pole. There can be papilledema or ocular palsy. So these are common presentations, either the retinal hemorrhages, papilledema, or neuropathies. Which neuropathies? 3, 4, 6, depending on the location. Coming to intracranial space occupying lesions. Whenever there is an intracranial space occupying lesion, such as when there is a tumor in the brain, what does happen? It leads to raised intracranial tension. So the first nerve which is getting affected when there is a raised intracranial tension is sixth nerve, which leads to lateral rectus palsy. So when there is a raised intracranial tension and there is papilledema, sixth nerve palsy, patient is having diplopia, you are suspecting or you are dealing with a case of space occupying lesion within the brain. There are many other focal signs of intracranial marsh lesions like prefrontal tumors, temporal lobe tumors, parietal lobe tumors, occipital lobe tumors. So depending on the location of the tumor, they have various ocular manifestations. If it is prefrontal tumor, then the patient is likely to have Foster Kennedy syndrome. So in the side where the tumor is there, that side patient will be having optic atrophy, and in the other eye patient will be having papilledema. So such condition is called as optic Foster Kennedy syndrome. So what happens when there is a parietal lobe tumor? When the parietal lobe tumor is present, so superotemporal fibers of the visual pathway are affected. So the patient will have a quadrantonopia, the visual field defect will be like this, as shown in the picture. It is called as pi in the floor. It is congruous. The congruous means both sides. It is on the left side only. So it is left homonymous or left congruous quadrantonopia. So this is commonly seen in parietal lobe tumor. When it comes to temporal lobe tumor, the patients have similar type of field defect, but the quadrantonopia is in the superior half. So that means it is called as superiotemporal field defects or pie in the sky. When the patient is having tumor in the occipital lobe, or when there is a problem in the occipital lobe, if it is vascular defect, you see something like this called as left homonymous hemianopia. So this is left side field defect is affected, so it is left homonymous. Homonymous means both sides it is similar. So left homonymous hemianopia, and you can see a small area is spared in the center, that is called as macular sparing, because the macular fibers are not involved. Now, we have dealt with intracranial space occupying lesions, which can lead to various types of field defects. Now, coming to midbrain. So, what happens in midbrain tumors? Midbrain tumors are mainly, you can divide them into upper part and intermediate part or the lower part. In the upper part, the patients have difficulty in upward movements. The patient is not able to look up. The vertical movements are affected. When you ask the patient to look up, he is not able to look up. There is spasmodic contraction. The upper lid contracts first, and then slowly it goes into ptosis. So when the patient is not normally, when we are looking left and right, up and down, that is normal. That is called as conjugate movements. It means both eyes are moving equally. When the patient is not able to look up, then there is loss of upward conjugate movements. Then you are suspecting a problem in the midbrain. In the lower part, when the third nerve is affected, then you suspect either Weber syndrome or Benedict syndrome. The third nerve palsy with hemiplegia, which is on the other side, contralateral side, with upper motor neuron type of facial palsy, it is called as Weber syndrome. When third nerve palsy with tremors on the contralateral side, then it is called as Benedict syndrome. So if the patient is having third nerve palsy, you have to rule out whether the patient is having contralateral hemiplegia or any tremors, or is having in whether both the features are present or not. What happens if the patient's pons is getting affected? When the pons is affected, the patient can present with two types of syndrome, that is millard buble syndrome and fovea syndrome. So what is millard buble or MGS syndrome? It's ipsilateral sixth nerve palsy with contralateral hemiplegia and ipsilateral seventh nerve palsy. When there is a sixth nerve palsy and loss of, when there is no sixth nerve palsy and it has all the features of millard buble syndrome, then it is called as fovea syndrome. So there is loss of conjugate movements on the same side, but all the features of millard buble syndrome is present, then it is called as fovea syndrome. Coming to cerebellar tumors, when there is a tumor in the cerebellopontine region, the patient presents with corneal anesthesia, because 5, 6, 7, 8, all these nerves are involved. There is an auditory problem, there is a facial paresthesia, there is a lateral rectus palsy, corneal anesthesia. All the clinical features of the involvement of 5th, 6th, 7th, 8th nerve is, which is associated with ataxia, papilledema, nystagmus. Then you suspect cerebellopontine angle tumors. If there is a tumor or if there is a problem in the chiasma, this is how the patient presents with field defect. It is called as bitemporal hemianopia, because the temporal aspects of the fields are affected and it is present in both eyes, so it is called as bitemporal hemianopia. So till now we have dealt with intracranial hemorrhages, aneurysms, and intracranial space occupying lesions and infections. The last one is demyelinating diseases. So what does this demyelinating diseases cause? These demyelinating diseases are nothing but they affect the optic nerve and they show manifestations of optic neuropathy or optic neuritis. These demyelinating diseases could be ascending or could be descending. So, for example, in multiple sclerosis, patient presents with optic neuritis and internuclear ophthalmoplegia and vestibular or cerebellar nystagmus. So basically, in patients with multiple sclerosis, optic neuritis is one of the main manifestations. What is internuclear ophthalmoplegia? We will deal with it on some other day. But today, as of today, if you think if multiple sclerosis is nothing but a demyelinating condition which affects the white matter of the spinal cord and brain, so its common manifestation is optic neuritis. There is another condition called neuromyelitis optica. Neuromyelitis optica, Defects disease, is nothing but patient presents with bilateral optic neuritis, and there is progressive quadriplegia and anesthesia. It is called as ascending myelitis. Means the inflammation of the white matter starts from the lower spinal cord and it reaches to the central nervous system or the brain, whereas multiple sclerosis starts from the brain white matter and then progresses as downwards. So one is descending and one is ascending. In both these conditions, the classic manifestations are optic neuritis. So whenever a patient is having optic neuritis, you have to check whether the patient is having good movements or not, whether there is how is the systemic, his motor condition, sensory condition also has to be assessed. There is another condition called as diffuse sclerosis or Schindler's disease. Here there is progressive demyelination of the entire white matter of the cerebral hemisphere. So what is its manifestations? It can be either papillitis or retrobulbar neuritis or basically optic neuritis. And the patient can have cortical blindness due to destruction of visual centers and optic radiations, and patient can also have ophthalmoplegia and nystagmus. Ophthalmoplegia means nothing but eye is not able to move in any direction. Eye is fixed in the center. So these are all examples of demyelinating conditions. So in today's class, we have just discussed about main features. What is anterior ischemic optic neuropathy? What are the various field defects seen? And what are the various manifestations of intracranial infections, space occupying lesions, hemorrhages, aneurysms, and demyelinating diseases? In all these conditions, demyelinating and anterior ischemic optic neuropathy, there is a swelling of the disc, and the classic features of any swelling of the disc is decreased contrast sensitivity, color vision, visual effective is affected, and altitudinal field defect of the central or centrocecal field defects. So these are common for all these types of conditions, and based on the type of the central nervous system involved and the location involved, the presentation differs. So depending upon the location, whether there is a neuropathy associated with optic nerve or whether just optic nerve is involved, or whether there is a involvement of surrounding blood vessels, Horner syndrome, sympathetic plexus, depending on the condition, we try to localize the lesion. Okay, so with this we complete today's topic. I have forwarded the PowerPoint to your class representative. You can just go through the PowerPoint and read the textbook. So if you have any clarifications, you can always approach us. So any questions?